people are there. So let's start. So good evening, everyone, and it gives us immense pleasure to welcome you all for our international webinar. We did have some break because of all the important meetings that we had, the SEOP, the FOCON, where you all participated in great numbers, and now we are back on track with our international and national education program that Pediatric Hematology Oncology chapter of Indian Academy of Pediatrics conducts once a month. So today, Vinod, myself, Badira, Dr. Banavli, we all welcome you for this very interesting session and a very important session on pediatric acute lymphoblastic leukemia cytogenetics. And we have an authority in this subject who is going to present his, thoughts on this important topic. And indeed a big honor that Dr. Anthony Mooman, Professor of Genetic Epidemiology, Newcastle University, has kindly agreed to deliver this important talk to all of us. Dr. Moorman, as I said, he's at Newcastle University. He's also the co-director of the Leukemia Research Cytogenetics Group, which was established in 2004. And he has had a very important university positions, being the cancer lead in the precision medicine, genomics, and informatics team in 2020, the pediatric oncology and leukemia lead with the Center for Cancer in 2019, and REF Impact Case Studies Working Group leader, which is in the Faculty of Medical Sciences in 2017. He's, holding many important national roles and committee membership positions, and the list is really long. And I would say that, his educational qualification and previous appointments are all, a story to tell. And he has currently also many major fundings on the leukemia research. And some of them are very interesting, like the aneuploidy being the driver for the childhood cancer and as a target for novel therapies, and also evaluating the integrated and multi-biomarker driven risk stratification for pediatric ALL, which are very, very relevant for all of us. With just that very brief introduction for a very big leader in the field of ALL cytogenetics, I welcome you, Dr. Anthony, to this Indian forum where all the pediatric hematologists, oncologists are all, together under this umbrella of PHO chapter. And once again, a big thanks for you to agreeing to do that. And now with that, I hand over to you to take forward this lecture. And Vinod and Badira will help us do the question answer session at the end of this talk, where, our members are free to just ask their questions in the chat. And then, we can have a discussion on this subject. Thanks again. Over to you.
Thank you very much for the kind introduction, and it's very kind of you to have gone through my CV in such detail and pointed out all the things that I'm supposed to be doing. So it's a great honor to be asked to deliver this lecture. It's a subject that's very close to my heart, and it's been the subject of my research for my entire career, which began many years ago, too many to remember. But throughout that career, what I've always been trying to do has been to understand better what the genetic and the genomic landscape of pediatric acute lymphoblastic leukemia is, and also to how we can use that to treat patients more effectively. So throughout my career, what I've been doing in the UK and more latterly across Europe is to collect standard of care genetic data and also samples from patients that have been treated on a variety of clinical trials, and use the samples to increase the amount of genetic information we have on those patients, and then to analyze those data sets to see which ones are associated with a good outcome and a poor outcome, and most importantly, how we can then use those to treat patients more effectively in subsequent trials. So The overview of the lecture that I'm going to give today is I'm going to talk a little bit about what are the principal types of genetic abnormality that are present in the leukemic blasts of these patients, and refer to a couple of well-known classifications, and then talk mostly about how these abnormalities are used to help the diagnosis and treatment of ALL. A little bit about how we integrate genetics with other risk factors such as MRD. And then finally, I'll talk a little bit about what genetic abnormalities diagnostic laboratories should be screening for and how to go about doing that. And throughout most of the talk, I'm going to refer to the Altogether One trial as an example. And this is a trial that we've been running in the UK and across 14 European countries, where we've successfully managed to integrate genetics and other risk factors to assign patients to treatment risk groups. So as you'll all be aware, the spectrum of somatic genetic abnormalities in acute lymphoblastic leukemia is highly varied, and it stretches from chromosomal translocations to aneuploidy, as well as deletions and sequence mutations. And it's essentially the same spectrum of abnormalities that you would see in any cancer. But of course, the genes that are being targeted in acute lymphoblastic leukemia are typically quite specific to that particular disease. And unlike some of the solid tumors, there's far fewer sequence mutations and more reliance on things like gene fusions and chromosomal translocations. So one thing that we can do in acute lymphoblastic leukemia now is think about the spectrum of abnormalities in this disease in two broad groups. And these are not silos. Some abnormalities may appear in two groups, but if we think about them in these two groups, it does help to think about how we can use this in the clinical scenario. So on the left-hand side of this table, we have primary chromosomal abnormalities. And these are often chromosomal translocations which result in a gene fusion, with the 922 translocation and BCR-ABL being the classic example, ploidy subgroups. And importantly, these abnormalities are considered to be clonal. So these are present in every single leukemia cell in the patient, and usually, although not necessarily always, occur in utero. Importantly, they're retained at relapse. So you will always see the same primary abnormality in a diagnostic scenario and a relapse scenario. So if you see a different abnormality at relapse to the one at diagnosis, either it's not a primary abnormality, or what you're dealing with there is a secondary acute lymphoblastic leukemia rather than a relapse of the original disease. If you do gene expression profiling on patient samples, these primary abnormalities are typically associated and define distinct subtypes. And usually they're strongly linked to outcome. Some of the more newly identified ones, we haven't got as much data as necessary, but the ones that have been known for a while, there are strong links with outcome, and there is usually consensus across the international community as to what the risk status is of those abnormalities. And when we examine the genes that are targeted by these primary abnormalities, they often target leukemia-specific genes and pathways. In contrast, the secondary abnormalities are typically of microdeletions or sequence mutations. By definition, they are subclonal, so they may be present in a very high proportion of cells, but they won't be present in every single of all the cells of the disease. And this is what gives the genetic and genomic heterogeneity that we see in this disease. Importantly, these abnormalities can be gained or lost in between diagnosis and relapse, and they can also be have changes in the proportion of cells that carry that abnormality. Typically, the secondary abnormalities will occur across all the primary subgroups, but at varying frequency. And there are a few examples of where secondary abnormalities are very tightly correlated with primary abnormality. And here, their prognostic effect is much more context dependent. And there's much more disagreement in the literature about what their prognostic impact is. And usually the disagreement is because the analyses of those papers have not taken into account what the primary abnormality is of those patients, either because they don't know or because they simply didn't look. And if you examine the typical cancer genes and processes that these secondary abnormalities targeted, they're frequently generic cancer genes and processes such as RAS pathway, TP53. These are ones that occur in the majority of cancers that we know. So over the last couple of years, there have been two very good papers that have come out that describe the genetic classification of ALL. They are largely overlapping in what they say, but there are some subtle differences. And the one on the left that is published by Charles Mulligan and his colleagues is probably the more complete and more up-to-date of the two publications. So if you don't have time to read both, I would definitely read the one on the left as your first one. And if we just consider B-cell precursor ALL for the moment, this slide here basically drills down what's known in those two papers into three simple tables. The table on the left are the classic chromosomal abnormalities and ploidy subgroups that we have known about for many, many years. These are all typically easily identifiable by standard cytogenetic and FISH techniques, and we have quite a lot of prognostic information about them. The table in the middle that I've called the genomic abnormalities, these are the newly defined genetic abnormalities that varying sequencing technologies have identified over the last 5 to 10 years. The numbers of patients that we know about with these abnormalities are typically far fewer, and we know less about their prognostic significance, although data is emerging. The table on the left are the gene expression profiles that have been defined. For example, the BCR-ABL-like, which I'm going to talk about more in the next few slides, PAX5ALT, ETV6, etc. These are much more diagnostically challenging because it's very difficult to replicate gene expression profiles from one lab to another. And my opinion is that what is more relevant clinically are the underlying genomic abnormalities within these gene expression profiles rather than the gene expression profile itself. And I'm going to talk through the BCR-ABL-like as an example in a few moments. But if we take that table and try to superimpose on that what we know about the prognostic relevance of those abnormalities, many of these can fall into one of 6 groups. There are 2 very large groups that have a very good outcome, ETV6, RONX1, and high hyperdiploidy. There's another 3 that are putative good risk abnormalities from the newer cohort. There are some high-risk abnormalities shown here in red. Most of these are well known, but we would probably include the MEF2D and the CDX2 one down here from the newer group. There are some groups that I've called very high risk, which are the TCF3HLF, which is a very high risk abnormality, and also MYC rearrangements. There are also some with some mixed evidence where we need to find more information. But then we also have these 2 that require targeted therapy, and this is the BCR-ABL and also the ABL class fusions. And this is what I want to talk about over the next couple of slides. Oh, sorry, I forgot that a bit of animation there. But this comes down to the gene expression profiling that I mentioned before. So BCR-ABL-like is a gene expression profile where it groups together a group of patients that have the same gene expression as BCR-ABL cases, but do not have that underlying canonical gene fusion. And 2 groups identified this abnormality many years ago now, one in the States and one over in Europe. The group in the States called it the Philadelphia-like gene expression profile, and the one in Europe called it the BCR-ABL. And they both found that it accounted for about 50% of B-other cases, or about 10 to 15% of BCR-ABL, and it was associated overall with a poor outcome. But the important thing to note is these 2 gene expression profiles are not identical. So if you apply the same profile to a completely independent set of samples, many of the patients will fall into both profiles, but you will have some patients that will have a BCR-ABL-like gene expression profile, but not a Philadelphia-like gene expression profile, and the other way around. But what followed on from this initial discovery was the spectrum of genetic abnormalities that underpin the majority of patients with one of these gene expression profiles. And we can think about these abnormalities in two broad groups. One, which I call the ABL class fusions, which result in constitutive activation of the ABL pathway almost identically to the way BCR-ABL works. And these are a spectrum of abnormalities where the hub genes are ABL1, ABL2, CSF1R, and the two PGFR genes, alpha and beta. And collectively, these group of abnormalities are known as the ABL class fusion. And there was good in vitro evidence that these patients respond to tyrosine kinase inhibitors like patients with BCR-ABL. The second group revolve around gene fusions involving JAK2, the overexpression of EPOR, and the overexpression of CLRF2, often by the IGH promoter. Now, these I've grouped together and I call the JAK-STAT abnormalities. And although they have constitutive activation of the JAK-STAT pathway, they do behave slightly differently to the ABL class fusions. They have been suggested to be poor risk. There has also been a suggestion that they will respond to JAK2 inhibitors, but there is relatively little clinical evidence to support that at the moment. What we noticed in the UK is that when we looked at the risk of relapse for these two subtypes in UCAL 2003, which is a trial we ran a while back, the patients with the ABL class fusion had a very high risk of relapse and also a very high level of MRD at the end of induction. And this was significantly higher than those patients with the JAK-STAT abnormality and other patients with B-cell precursor ALL. So on the back of this observation and the fact that there was good in vitro evidence that they responded to imatinib, we then screened patients in our next trial, UCAL 2011, for ABL class fusions if they had high levels of MRD at the end of induction. And we found a wide spectrum of abnormalities as shown by this pie chart, with the majority of cases that we found having the EBF1 PGFR fusion. Interestingly, we also found patients with these fusions in TALL as well as BALL, whereas previously it had thought that most of these cases were in a B-cell precursor ALL. When we found these patients, imatinib was added to their chemotherapy backbone at the end of induction and continued for the rest of their therapy. And when we did the last follow-up on these patients, we found that this intervention massively reduced the risk of relapse for these ABL class fusions. So this graph here shows the relapse rate in the control group and also the TKI group. So this intervention happened approximately halfway through the UCAL 2011 trial. So we had a cohort of patients that we didn't screen and then a cohort of patients that we did screen. So that's what the difference between the TKI and the control group. So the control group did not receive TKI at the end of induction, whereas the TKI group did. And you can see that although the follow-up is slightly shorter for the TKI group, they have no relapses at all. There were 2 deaths in this group after a bone marrow transplant, but so far we haven't seen any relapses, indicating firstly that this intervention worked well for BCR-ABL, but it also illustrates the fact that this doesn't apply to all patients with that gene expression profile, which is why I've always been a keen advocate of looking at the underlying genomic abnormalities and not just the gene expression profile. So the next topic that I want to move on to is the importance of chromosome number. So I've mentioned several times before that we have these ploidy subgroups such as high hyperdiploidy, which I'm going to talk about in a minute. But I just want to say a few words about the near haploidy and the low hypodiploidy groups, because although they're rare, these are clinically very important groups. So the near haploidy patients have just 24 to 29 chromosomes in their leukemia karyotype, which means they've had a massive loss of chromosomes. And the low hypodiploidy have 30 to 39. Now, although they've all lost chromosomes, there's a clear distinction between near haploidy and low hypodiploidy. And the major difference here is the presence of TP53 mutations. So these are almost ubiquitously present in low hypodiploidy, but never in near haploidy. And this is what marks them out as being different. Now, although you have about 95 upwards percent of low hypodiploidies having TP53 mutations, only in childhood ALL, only about 50% of these are somatic. The remaining 50% are actually germline TP53 mutations, which means these patients have a Li-Fraumeni syndrome. So clinically and diagnostically, it's important to distinguish these, because if you do see this abnormality in a child with ALL, you do need to think about whether or not this patient actually has Li-Fraumeni syndrome. And in the UK, this now prompts a germline genetic investigation. The other important thing to point out with these two subgroups is that they can both present as mass cases. And this is because of the fact that they can both undergo whole genome duplication. And if you have whole genome duplication from near haploidy or low hypodiploidy, you actually end up with the number of chromosomes that could be classified as high hypodiploidy. And given that that has a very good outcome, this causes a diagnostic dilemma. So the clear way round that is to use SNP arrays diagnostically, which is what we do in the UK now, because using SNP arrays, you can very easily see the widespread copy number neutral loss of heterozygosity that is associated with that mass status. So at the other end of the spectrum, we have high hypodiploidy, which I've mentioned before. So this has, instead of a loss of chromosomes, this has a massive gain of chromosomes, taking the modal chromosome number up to 51 to 67 chromosomes. It's the most common subgroup in pediatric ALL, accounting for about a third of all cases with B-cell precursor ALL, and it universally has a good outcome. It's important to note that the spectrum of chromosomes that are gained within high hypodiploidy are non-random, and over 75% of the chromosomes gained are one of those peak chromosomes shown in the bottom right-hand side of this slide. And there's been a lot of interest about whether the specific gain of chromosomes are associated with a good outcome. And there's an ongoing debate at the moment, which we haven't fully resolved, about exactly what is the best definition of low risk high hypodiploidy. So many groups have suggested, like the Children's Oncology group in the States, that the triple trisomy of 4, 10, 17 is the optimal definition. But in the UK, we've never found that to be the case. And that could be down to differences in therapy or the underlying population. And what we have tried to do is find a novel definition of low risk high hypodiploidy. And for this, we used a couple of our cohorts and a lot of machine learning algorithms and came up with this new profile, which was based on the gain of chromosomes 17 and 18, but also chromosome 5 and 20. And this little algorithm here can divide high hypodiploidy into good risk and poor risk, which have a very clear difference in outcome as shown by this relapse rate here. So the good risk has an outcome with a relapse rate of just 5%, whereas the poor risk group here has a relapse rate of about 16%, which is much more akin to patients with intermediate risk cytogenetics rather than good risk cytogenetics. And what people are trying to do now is to determine what is the most appropriate definition. And this slide, that table I've taken from a recent paper by the St. Jude's group published in the Journal of Clinical Oncology, has taken a variety of different criteria of high hypodiploidy, the classic definition, the Children's Oncology definition, our definition, and also a DNA index version to look to see what has the best outcome. And you can see from the data on these slides that they all have a good outcome. What is different is the size of the population you capture with each of those definitions. So clearly, the definition that picks up the most cases is the traditional chromosome number. The triple trisomy has a very low risk of relapse, but has a much smaller, you identify a much smaller group of patients. Whereas if you go to the R definition and also DNA index, then it goes up significantly, much nearer the total definition. And also there are optimal detection methods for each of these abnormalities. So in terms of using this in a clinical setting, one of the questions you need to ask is, What kind of size of low risk group do I want? What is an acceptable relapse risk? And what detection method do I have? If you don't have the ability to do SNP array, FISH, and cytogenetics, then obviously you can determine your DNA index very rapidly using flow cytometry. And actually, that's quite a good method if that is your option. But obviously, if you have genomics set up to detect other abnormalities, then you can think about using an alternative definition. So in terms of the newer abnormalities that have been detected, this pie chart just shows the frequency of these abnormalities in B or the ALL, which basically means the ones that don't have the archetypal cytogenetic abnormalities. And you can see that the PAX5 alt and the DUX4 account for nearly 50% of these patients, with ABL class, CLRF2 and ZNF384 picking up reasonable sizes. I've already talked about the poor outcome associated with ABL class fusions. There's growing evidence that patients with a DUX4 rearrangement have a very low risk of relapse. However, these patients are often associated with higher levels of MRD at the end of induction and are often older patients. So typically in the risk stratification algorithms that we've used, they have received more intensive therapy. So we don't know whether this good risk is because many of them received more therapy or whether they are intrinsic good risk patients like ETV6-RUNX1. And that's something that we're trying to unravel at the moment. And the patients with ETV6-RUNX1, like in our hands, had a very good outcome with no relapses or deaths, but that's not universally been reported across different studies. So this is actually what I was saying with IGH-DUX4. Sorry, these are the slides showing the very good outcome, but also the fact that they have high levels of MRD at the end of induction, and they are typically treated on more intensive protocols, unlike the ETV6 RUNX1 patients. So it's important to remember that the frequency of all these genomic abnormalities is hugely age-related. So overall, the pattern looks like this, with the majority of pediatric and teenagers and young adults having a good risk abnormality, with that declining with age. So by the time you get into adult ALL, you have a preponderance of high risk abnormalities. The one that stands out as being different is the infants, which, as I'm sure you all know, have a very high risk of KMT2A gene rearrangements. So moving on now to think about secondary abnormalities and how they are being used. So this slide just shows the spectrum of microdeletions and mutations that you often see in ALL. And you can think about these in four subgroups that I've shown over there. But in terms of the way they've been used clinically, their actual underlying function has not really been, it does not really affect the way they've been used. So by far the most frequently used abnormality in terms of prognosis are deletions, specifically Icarus deletions. And these were discovered by Charles Mulligan and et al. In his seminal paper back in 2007 using SNP arrays. But more recently, many groups around Europe have been using a technique called MLPA to rapidly detect deletions that are affecting genes that are commonly deleted in ALL. And three groups, the Dutch Children's Oncology Group, Dana-Farber, and the Belgian-French group, EORTC, now allocate patients with an Icarus deletion to alternative therapy. So the Dutch are giving them longer maintenance, which they published in JCO a couple of years ago, reduce the risk of relapse. The Dana-Farber allocate these patients to the high-risk arm, whereas the EORTC trial gives these patients pulses during maintenance. The latter two have not reported on the effect of that. So in the UK, we have adopted a slightly different approach. Rather than just using Icarus, we've developed what we call the UCAL CNA classifier, which identifies a good risk profile and a poor risk profile based on the deletion status of 8 of the most common regions that are deleted. And you can see from this little graph on the right-hand side that within patients with intermediate risk cytogenetics, if you have a good CNA profile, you have a very good outcome, much more akin to those that have ETV6 and high hyperdiploidy. Whereas if you have a poor risk profile, then your outcome is much nearer kind of 75%, which for us is relatively low. So in the altogether trial, we're actually using the good risk component to de-escalate patients with a good risk profile rather than escalate the ones with a poor risk profile. In contrast, the Germans and the Italians have identified the Icarus Plus profile, which is the presence of an Icarus deletion with additional deletions, as described there on the slide. And they have shown that in patients with intermediate levels of MRD at the end of induction, the Icarus profile is associated with a much higher risk of relapse, and importantly, much higher than the presence shown in yellow here of those that just have an Icarus deletion. So you have a situation here where you have a multitude of different profiles and trials, all using copy number alterations in different ways to risk stratify patients. Now, in all probability, all these approaches are right, and they kind of fit in with what clinical trial and question is being addressed by that trial. But they are all quite different, which is very different to the way that we have used classic chromosomal abnormalities in the past. So I've not really had time to talk about TALL. And as I'm sure you're probably aware, there's been this huge study that the Children's Oncology Group have published based on genomic analysis of about 1,300 patients with TALL, which is just a massive resource. They have identified multiple different abnormalities that are associated with outcome, but the numbers of patients in each of these groups is sometimes very small. And you can see from this table here that some of these subgroups are like, 10, 8 patients, 18 patients, which is just bewilderingly complicated to know how to actually use that clinically going forward. What has been published very recently is another paper from the French group, which have used a simpler profile based on the mutation and deletion status of a handful of genes in order to be able to classify patients into either a good risk or a poor risk genetic thing, a group, and then they combine that with white cell count and MRD to identify 3 groups that are clinically quite relevant. So it's undoubtedly the Children's Oncology Group is going to fuel research going forward and is probably the ultimate solution. But in the meantime, I think a lot of people are going to be taking this approach in TALL, which is much more manageable in the diagnostic and the clinical setting. So just to give you an idea about how we've done this within the Altogether Consortium. So I mentioned that Altogether Consortium comprises 14 countries in Northern and Western Europe, as shown here on this map. Germany is in this lighter color, principally because part of Germany is in the Altogether Consortium and the rest of it is in the BFM Consortium. So the BFM is the big part of Germany, the little part is in the Altogether Consortium. But this consortium has been running for many years now, and we've got several thousand patients recruited onto our trial, and we've incorporated a lot of this kind of risk stratification in our plans. So importantly, when we started this initiative, we had no legacy algorithm to use because we'd all been using something different. So essentially, we started from scratch. We knew that we wanted to have MRD at the end of induction as one of our primary decision points. And we also knew quite a lot about what we had previously done with high-risk genetic abnormalities. And so we could use those 2 features to separate kind of a standard risk group and a high risk group, but the bulk of the patients fell in the middle, about 70%. So we had to think about how we would go about risk stratifying that bulk of patients that had intermediate risk genetics, intermediate risk MRD. So what we did is we pulled data from our respective cohorts that had this particular definition, and we looked at it in several different ways. And the key thing that we looked at was how do we integrate genetics and treatment response data. And we used this paper that we had published back in 2018 as a kind of our first point. And what this paper shows that if you look at the distribution of MRD at the end of induction, it's log normally distributed, which is no big surprise. And what we've done here on this graph is we've colored the different segments of this graph according to your risk of relapse. So again, this is not particularly surprising, but the higher the level of MRD at the end of induction, the higher your risk of relapse. That's pretty obvious. but it's surprising that no one had ever looked at that using MRD as a continuous variable rather than just using a binary. But what really stood out was when you take that data and you do that data across a range of different genetic backgrounds, you get essentially the same shape of curve. It can be shifted to the left or shifted to the right. But the key thing is for a given level of MRD shown in this dashed dot line, your risk of relapse was dependent on your genetic background. So you could no longer really say that if you had a MRD value of X, all those patients had the same risk of relapse, right? You had to integrate your MRD. And what this did show was that if you wanted to get the best out of MRD and the genetics, you had to integrate them so that you had a different different MRD threshold depending on your genetics. So when we took that idea and took it to the combined cohorts that we had collected across the consortium, we looked at a variety of different questions. We looked to see, was end of induction MRD more important than end of consolidation? And the answer for BALL is yes, it was. That's not necessarily because end of consolidation is not important, but actually the majority of cases are completely MRD negative, undetectable by that stage. So actually you had relatively little data to work with. So when the MRD techniques become more sensitive, that might come into play. But at the moment, it's end of induction that's most important. And we then looked at a variety of different genetic abnormalities and looked to see what the optimal MRD threshold was for each of those abnormalities. And we found a different optimal MRD threshold for different genetic abnormalities. And for TALL, we found something slightly different. There, the end of consolidation MRD was the most important risk factor. So what we did is we defined an intermediate low risk criteria, which was the combination of genetics with end of induction MRD, but using a different MRD threshold for different genetic subtypes. And when you combine patients with any of these criteria and compare them with all the other intermediate risk MRD, you can see from this graph on the top right that you have a very clear difference in outcome, with a much lower risk of relapse for the intermediate low compared to the intermediate high. And importantly, that difference maintains depending whether you look at NCI standard risk or high risk patients, and it's also consistent across all the underlying cohorts that were used to create this combined data set. So what we've done is we've incorporated all this into our risk stratification algorithm. So when a patient is diagnosed, if they have B cell precursor ALL and NCI standard risk, they get a 3-drug induction. Otherwise, they get a 4-drug induction. At the the presence of high-risk genetics needs to be determined by the end of day 15. And if they do have high-risk genetics, they move from the 3-drug to the 4-drug induction. At the end of induction, everyone has MRD measured. And if you have undetectable disease, but no high-risk genetics and your B cell, you moved into the standard therapy arm. If you have high-risk disease, which is 5%, or you have very high-risk genetics, which is basically just the TCF3 HLF fusion, you move into the high-risk group, and everyone else goes into the intermediate risk group. At the end of consolidation, MRD is measured again, and patients are then split into intermediate low, intermediate high, according to your genetics and your MRD, with patients over the age of 16 here always going into the intermediate high group. If at the end of induction you have persistent disease, then you move into the high risk group. The only addition there is the patients with targetable fusions. So these are the ABL class fusions. So these need to be identified by day 15 as well, and they get imatinib added to their standard chemotherapy at that time point. And they then continue on, and then they, based on their response, they'll either stay into the intermediate high risk group, or if they have persistent disease at the end of induction, at the end of consolidation, they move into the high risk group as shown here. Now, importantly, in terms of our randomizations, these two green groups here, which account for at least 50% of our patients, have a treatment reduction question. The dark group here, the intermediate high, this is a novel drug, inotuzumab, and also a maintenance therapy question. And then finally,
There seems to be some technical glitch, and I think we have lost the screen.
Hello, sir, can you share again?
Dr. Anthony, we can't hear you. If you can just unmute yourself.
sorry, can you? Oh,
Yeah, we
can you
can hear you
what
now.
happened there?
So I don't know, some technical thing happened.
Sorry.
We saw that algorithm that you showed, the risk stratification, the newer risk stratification, and then so we
Yeah.
were there almost at the green and the blue and the red box at the bottom.
Okay. I'll read that. Sorry about that. So what I was just saying at the end there was this treatment algorithm places patients into one of essentially 5 treatment pathways. You've got the standard risk pathway, the intermediate low, intermediate high, and the high risk, with the able class fusions making up the 5th. And the intermediate low and the standard risk group account for about 50% of our patients. And these are all randomized to a treatment reduction question. So they're getting less chemotherapy because they've been identified as having a low risk of relapse. The intermediate high risk group has a novel drug, which is inotuzumab, and also randomization to a maintenance therapy question. Whereas finally, the high risk group, shown here in red, which is about 5% of our patients, either get a CAR T cell or a transplant. So the modification that we've made recently on Altogether is to incorporate patients that have B cell precursor ALL and an Ig-MYC rearrangement. Now, historically, these patients have been classified often as lymphoma because of the involvement of the MYC gene, but a study by my colleagues Lisa Russell and Simon Bonkin here at Newcastle showed, using a cohort of 90 patients, if you do extensive genomic analysis, you can identify 3 clear subgroups of patients with Ig-MYC. You have a group that have coexistence of BCL2 and BCL6, and these are classic lymphoma type patients, and on using gene expression profiling and methylation, they cluster separately with the lymphomas. Whereas these other 2 groups shown here in green and blue do not cluster with the lymphoma patients, and they have discrete methylation and gene expression profiles. There's one where shown in blue where Ig-MYC is the only defining feature, and then there's this other group, a smaller group, where the Ig-MYC coexisted with another established B cell precursor ALL abnormality and was actually a secondary abnormality. So these 2 groups shown in green and blue are now included in the Altogether protocol as high-risk patients. So obviously, having all these genetic abnormalities in our protocol and the way that we've used MRD has had implications for the genetic abnormalities in the UK and the other countries. So the turnaround times have changed dramatically, with the requirement to identify able class fusion patients by day 15. Most countries were already identifying the other high risk abnormalities by day 15, so that wasn't really a change. The detection of ETV6 RUNX1 and high hybrid diploidy now became mandatory, because although many of our protocols had identified them as good risk patients, they weren't actually used to change therapy. So testing for them wasn't always mandatory. But that needs to be required now by day 56. And also we have to be able to detect the copy number profile also by day 56. So that was a big change for certainly the labs in the UK, but most countries in Europe. That's been a big change. So what we have done is we've developed some screening guidelines for the labs being used for the Altogether protocol to identify the most appropriate technique to identify these patients. And essentially, the one thing that we've really been pushing is the use of SNP arrays, because I've already mentioned it's very easy to identify aneuploidy groups by using the SNP array. It also distinguishes the patients with MAS, low hyperdiploidy, and near haploidy from high hyperdiploidy. It's also good for all the copy number alterations and also IAMP21, which I've not mentioned specifically, but it's readily good for that. And we've also pointed out that FISH can be used to readily detect most of the gene fusions. So if you use SNP array with FISH, the combination of FISH probes, you can actually easily detect all the abnormalities required within Altogether. The only shift that we've seen in labs over the last couple of years in the UK is to move away from FISH and to use an RNA fusion panel, which is quicker, and if you've got a reasonable size lab, can actually end up being more cost effective. So this is a typical workflow. This is the Newcastle NHS diagnostic lab that my colleague Gavin Cuthbert runs. And essentially, when you get a bone marrow aspirate or blood sample coming in, the two things that happen first is the SNP array, then a primary FISH panel. If the primary FISH panel is negative, then you do the Able class FISH panel. And finally, if both of those are negative, then you pick up the RNA that was stored and you do an RNA fusion panel. And using this system, you have an integrated report within 12 days of the sample arriving, which works very well in that laboratory. I should point out that not every lab in the UK uses this exact workflow. They all have their own workflow. The obvious thing that's missing from this workflow, and indeed is missing from most workflows in the UK now, is good old-fashioned cytogenetics. Very few labs do karyotyping anymore, which is a shame because I like the data that it produces. It served me well in my research career, but nowadays very few labs do it because it's not the most effective way of detecting these abnormalities. So in conclusion, ALL can now be classified into genomic subtypes. If you do whole genome sequencing or an equivalent, you can classify virtually every single patient into one of those abnormalities that were in those classification papers that I showed you at the beginning. The genomics has identified lots of new abnormalities. Some of them are clinically actionable, like the Able class 1 fusion, the Able class fusions, and also the CNA profiles. They are, useful clinically going forward. Overall, genetics now really does matter in the treatment of ALL. It's likely that more risk stratification will be on its way. Integrating genetics and MRD is going to be absolutely key. And also, there are many novel agents that have been developed to target some of these specific lesions. Not many of them are used clinically, apart from the obvious one of TKI, but I do believe that over the next coming years, more of these will come online. So I'd just like to end by thanking my fellow members of the Leukemia Research Cytogenetics group, especially Christine, that has been co-directing it with me for many years now. She's actually just retired, and also my other colleagues, all of whom have made a big contribution. The other big thanks I'd like to make is to the many clinicians that I have worked with over the years. In the UK on these frontline trials. I haven't talked about any of the relapse trials that I've worked on with Vasgar, but today's been focused on frontline trials. But our collaboration with these clinicians has been very important to take forward a lot of these research. And similarly, all the work that I've done on adult ALL as well that I haven't gone into today. And also all the funders that have made this work possible. And finally, the patients and their families for agreeing to go on these clinical trials. Because, of course, if that hadn't happened, we never would have been able to put together these data sets to do this kind of analysis. So thank you very much again for the invitation to talk to you today. And I'm more than happy to take questions from you now. And if you are going to the EMBO workshop in Calcutta the week after next, I will see you there and you can ask me questions then as well. So thank you very much.
Okay, thank you, Dr. Anthony, for your wonderful lecture. From your lecture, I think we can understand that the cytogenetics is becoming more and more complex, but you have made it quite simpler in your lecture. So I think we'll go on to the question box, chat box. So Dr. Priyanka has asked this question, like, how do we interpret ETV6 RUNX1 fusion when associated deletions are present? Will it still be a low risk, or do we escalate?
That's a very good question, and it's something that I have been trying to address for a number of years. So in my research at the moment, there are no known secondary abnormalities that substantially change the low risk associated with ETV6-RUNX1. There have been many papers out there that have suggested deletion of the second ETV6 allele, complex karyotype, when we decrease the risk. However, in the research that we've done, we've never been able to replicate those results. So at the moment, we don't feel that there is anything that is particularly relevant. However, that doesn't mean to say that there isn't more research that needs to be done here. So we know that there are some patients with ETV6-RUNX1 who will relapse and will relapse very early. And we know that there are quite a few patients that will relapse and then relapse again and relapse again. But predicting those is actually quite challenging. So we've been doing a project with Monique Den Boer based at the Princess Maxima Center in the Netherlands. And she and her colleagues have pulled together a reasonably large cohort of these so-called high-risk ETV6-RUNX1 patients and has employed a number of whole genome techniques to see if she can find any genetic determinants of that high risk in those patients. But at the moment, that data is still being analysed. So at the moment, we don't have any. So I suspect there might be a handful of ETV6-RUNX1 patients that do have high-risk underlying genetic abnormalities, but we just don't know what they are yet. But hopefully we will find them.
Thank you, sir. Next question from Dr. Prashant, like, what would be the added benefit of testing IKZF1 mutation in addition to IKZF1 deletion?
So another good question. The answer to that, in my opinion, is very marginal. There are relatively few ETV6-1 mutations. Where they are of real interest is germline ETV6-RUNX1 mutations, which have an increased risk, but they are very rare, but very strongly associated with familial leukemia. But in reality, screening for them is not, you're not going to detect that many more patients. So overall, unless you are adopting a strategy where you're going to screen for gene mutations, I wouldn't start it just for looking for Icarus mutations. But if you have a panel that you're going to run anyway, yes, I would put Icarus 1 on it, but I wouldn't start it just for the Icarus.
Just in continuation to the same question, like, how would you risk stratify IKZF1 deletion with ERG deletion?
Right. So this is comes back to one of the points I was making at the beginning of the lecture, which is a lot of this is context dependent. So virtually every patient with an ERG deletion actually has a DUX4 rearrangement. So the primary abnormality there is the DUX4 rearrangement. And the presence of an ERG deletion and an Icarus deletion within that group at the moment does not seem to affect their outcome. So those, I would classify those patients in a good risk group. But as I mentioned before, we haven't unraveled that issue about whether their good outcome is due to the slightly more intermediate levels of therapy. So I wouldn't necessarily instantly put them into a treatment de-escalation pathway, but I would definitely consider them to have a good prognosis.
Okay, thank you. So next question from Dr. Venkatesh, whether CDKN2A2B deletion can be considered as equivalent to PH like ALL, and should we treat them as high risk?
So the answer to that is no. There are many, many patients which will have a CDKN2A deletion that will not have a Philadelphia-like gene expression profile. So you can't use it as a marker. I know there are lots of patients, lots of papers that have reported CDKN2A deletions to be, have a high risk of relapse, but there is no consistency to any of them. And it's always a secondary abnormality, and you always have to look at what the primary abnormality is. And in our data, it's rarely a prognostic indicator. The only area that I think is potentially relevant is in adult ALL, and even then only in patients with BCR-ABL positivity.
Thank you. So next from Dr. Mangai, potential targetable alterations for relapsed ALL. Do you see any future for this?
Yes, I do. I think I think there's good evidence now that if you patients with an ABL class fusion, if they relapse and have not been treated with a TKI up front, that they should have a TKI added. I am hopeful that patients with a JAK-STAT abnormality are targetable. I just don't think that the current crop of JAK2 inhibitors are the most effective drug to be used. But there is good indication that targeting that particular pathway is a good idea. We just have to find the right drug in order to do that. There's also growing evidence that patients with KMT2A can be targeted at relapse, as several other pathways. So I think there's probably quite a lot of further work to do in the relapse setting. In Europe, our approach has been to screen patients at diagnosis for existing mutations, and also to do drug response profiling, and then treat those patients accordingly with a panel of different drugs depending on what the answer to that. That's a trial that's being run out of the Princess Maxima. My colleague Frederick Van Delft is involved in that here in Newcastle from a UK perspective. That hasn't read out and hasn't been published yet, but I do think that that will be the route by which patients with relapsed ALL will be treated with those kind of targeted therapies.
Yes, okay. Moving to next from Dr. Chetan, regarding your data on JAK-STAT pathway mutations and the outcomes being better as compared to ABL class mutations without TKI. So just wanted to know if that's EFS or just OS.
Both.
Both.
So that's better whether you look at relapse-free survival, event-free survival, or overall survival.
Great. So just from interesting question from Dr. Gargi, like whether NGS can replace all conventional modes of testing ALL, or is it just an addition with the conventional testing techniques? Your approach, please.
So the answer is yes, it will be able to. It's a question of which technique you go for. So in the UK, our approach to integrating NGS has been to go down the whole genome sequencing route, which has been slightly controversial, but is quite effective. It's taking a reasonable amount of time to get up and running. But in England now, all children with acute lymphoblastic leukemia are eligible for whole genome sequencing at diagnosis. And the majority of centres in England are using that, and the ones that aren't using it at the moment are working towards it. So if you do whole genome sequencing, you will be able to detect all the abnormalities I've talked about today, and virtually everything that has been identified in acute lymphoblastic leukemia. We published a study a couple of years ago, led by my colleague Zara Ryan, and she did whole genome sequencing on about 210 patients with ALL that didn't have any of the easy to detect abnormalities. And of those, she only had about 4 or 5 at the end where she wasn't able to identify the primary chromosomal abnormality. So the only thing that is slightly tricky, well, there's several things about whole genome sequencing that is difficult. It costs a lot of money. You need a germline sample, but we've overcome that in England by using a skin biopsy. So the doctors take a skin biopsy just before they insert the needle for the bone marrow aspirate, and then they use that as the germline, and then the marrow as the tumor sample. So that works very well. A standard pipeline will identify most of the abnormalities. You do have to use a slightly different pipeline to accurately call DUX4 rearrangements. But apart from that, it will identify everything that we know about. There may be 1 or 2 abnormalities that you will need to do something different. But I think personally, I think that will be the ultimate solution. Whether the ultimate sequencing solution will be short read sequencing like Illumina or long read sequencing like Oxford Nanopore Technologies remains to be seen. I suspect that in 5-10 years' time, it will be the long read that wins out, because I think ultimately it will be easier to set up in smaller labs rather than the short read that largely needs to be done in a centralized manner. Many other countries are exploring the whole genome route, but many other are doing RNA-seq. And RNA-seq is very useful for detecting the vast majority of these abnormalities. It's a little bit, you have to use reasonably good pipelines and some more adventurous pipelines in order to call things like high hyperdiploidy and aneuploidy. So there are swings and roundabouts for RNA-seq. Certainly RNA-seq is probably the best way in pediatric AML. I know we haven't talked about that today, but I strongly suspect that's going to be the choice technique for pediatric AML. But in ALL, I still think some kind of DNA-based technique, because of that need to identify the aneuploidy, is going to be so important. So that's my opinion. If you want to go for a kind of a cheaper option, SNP array and RNA fusion panel is a great combination.
Thank you. That's quite interesting. And from Dr. Maharshi, we have 2 more questions. We'll stop with that. Dr. Maharshi would like to know whether the combination of MRD plus the cytogenetics, would it be the same for flow-based MRD, which we do most of the times in our country?
Yes. So at the moment, in altogether, we do PCR and flow MRD at all time points. And when we have looked at the end of induction MRD levels by flow and by PCR, it highly correlates. There are a few outliers at the very top end that have a little bit of difference, but essentially it works. And we've published several papers now where we have used data from flow MRD alongside data for PCR MRD, and we've never noticed any different in terms of our development of our models and algorithms. So you can use either, yes.
Okay, next from Dr. Amrita is whether the high hypodiploid 40 to 44 chromosomes, do they have any specific intervention?
Right. So this is a slightly controversial topic. So my opinion is no, they do not. So if your modal chromosome number is anywhere between 40 and 50, then essentially you need to classify your patients by the presence of some other abnormality, usually a gene fusion, but not by the aneuploidy. Now, this is a little bit controversial because a children's oncology group in the States have a slightly different definition of low hypodiploidy than I do. So if you remember, I said my low hypodiploidy group was 30 to 39, which is something that we've been using in the UK for many years and was, in my opinion, robustly defended by Charles Mulligan's whole genome sequencing paper, which he published in Nature Genetics. Nonetheless, the Children's Oncology Group have still had an upper limit of sometimes 44 chromosomes, sometimes 43 chromosomes, etc. So they've always had a slightly different upper limit. In our hands, those very few cases, they simply don't have a low hypodiploidy profile, and importantly, they don't have the TP53 mutation. So I don't think they belong with low hypodiploidy. And in altogether and in the UK, we've never classified them with the low hypodiploidies or high risk. And I think, but don't quote me on this, I think the children's oncology group might be moving towards an upper definition of 39 chromosomes as well, but we'll have to wait and see.
Okay, great.
The next question is from Chetan, where he has asked that with the advent of blinatumomab, do you think the need for all these gene mutations might also go out of fashion?
I hope not, because I've built my entire research career on them. But it's a very good question. And the answer is it's possible, yes. And in many respects, of course, I hope it is, because ultimately we're in this because we want the children to be cured more robustly. So there is good evidence now that blinatumomab in both the frontline and the relapse setting do have very good responses, irrespective of your genetic risk group. The caveat I would say to that is there are two caveats to that. At the moment, most of the robust analysis has been looking at all the genetic high risk groups together, because very few studies have been big enough to look at them individually. So we don't know whether there's going to be any variation amongst those high risk abnormalities. The second caveat is, although our traditional genetic risk factors appear to be, or blina appears to make them appears to be agnostic when you use blina, it's very likely there'll be other genetic abnormalities that will indicate blina resistance. And there is already a paper looking at patients with a PAX5 P80R mutation, suggesting that that will modulate your response to blinatumomab. There is also some evidence from an Australian study that was presented at the EHA conference, the European Hematology Association conference last year, which suggested that patients with TCF3 PBX1, the old-fashioned 119, did not respond as well to blinatumomab. And we have some very early data in the UK suggesting that there are some other of these genomic abnormalities that may not respond very rapidly to blinatumomab. So I think it's an exciting time because blinatumomab is a major disruptor in terms of the therapy of ALL. It undoubtedly is going to improve the outcome of our patients and is going to offer the opportunity to give our patients less chemotherapy. But I do think that there are going to be genetic and genomic determinants of blina response. And importantly, I think possibly the really big thing here is something that we haven't talked about at all today, and we have very little data on, and that is the germline genetics. And I think it's very possible that the germline genetic variation will have a bigger impact on the likelihood of you responding to blinatumomab than somatic genetics. So I think genetics is going to be important in the blina era, but it may be different genetics.
Last from Dr. Maharshi again on inotuzumab in this IR high-risk patients.
So the answer to that is we don't know yet, which is precisely why in altogether we're asking the question. So in the intermediate high-risk patients in altogether, they are being randomized to receive inotuzumab. So at the moment, we don't know whether that's going to be appropriate for these patients. I would say that it's possible. I think there is an indication that not that we have any data to suggest that it will be better, but I think there is data in the literature to suggest that it will be good. The big question is it going to be better than blinatumomab? And that's the answer that we don't know yet. And I think that will be very interesting. Certainly, blinatumomab seems to be the front runner at the moment.
Thanks. I think thanks again for taking your extra time in answering all the questions in the chat box.
Pleasure.
And I hand over to Dr. Manas for the closing. So unmute.
So many compliments for you. So thanks a lot for doing this. It was just fantastic. I think one of the best lectures that we have heard about ALL risk stratification and how it is evolving. And I think right from the first slide where you classified how the primary and the secondary abnormalities are, I think you had the attention of more than 140
Wow.
participants who attended this webinar. And if you permit us, after 6 months, we'll put this on our Indian Pediatric PHO channel, YouTube as well, which will help disseminate the information to many more doctors,
Yeah.
who will be able to watch this later in time. We have this 6 month lag time because we want to encourage people to attend it live. Otherwise,
Good idea.
when you have this thing on YouTube right away, everybody wants to watch it whenever they have time. So, thanks a lot, Dr. Anthony. It was just
Pleasure.
fantastic. Hope you have a very good stay in India and you
I
enjoy
will.
Kolkata, which is beautiful and rich in culture. And do visit us whenever you get a chance. Thank you,
Will do.
Vinod. Thank
Thank
you,
you.
Vinod, for
Yeah.
organizing this. Thank you, Badira, and thank you, Echo team, for giving us this platform to do this every month. Thanks a lot.
Excellent. Thank you all for listening and for your wonderful questions.